To the conversation, allow us to listen into this story that was compiled by our very own Elizabeth Atieno, just breaking down the numbers of what the situation is like based on that report from one hospital right here in Nairobi. Over to you, Liz.
This is the AIDS Healthcare Foundation Clinic in Mathare, Nairobi County. Every time when this facility tests approximately 20 samples for sexually transmitted infections, 15 samples turn out positive. This paints a grim picture of the spread of syphilis, gonorrhea, and chlamydia in Nairobi.
The positivity rate forms around 75% of the cases we see in a day. Actually, a bigger number of patients we see is adolescents and young people, forms the majority of the patients we see, but we still see adults also come in and treated for STI.
Some of the common symptoms of STIs include sores in the genital area, pain during urination or sex, and genital discharge. However, health experts have raised an alarm over the high number of STI patients in Nairobi who do not present any symptoms, thereby posing a serious health risk and a possible surge in transmissions.
At least 50% of the clients we see in the wellness clinic don't have symptoms.
It's not a must that you have any symptoms that's suggestive of an STI, but you can also just come here to be screened for that and get to be diagnosed and also offer treatment.
Some of those STIs, they break the skin around the private parts and therefore making it easy for the virus to enter the body.
In order to prevent the spread of STIs, Kenyans have been urged to avoid multiple sexual partners. Those found with the infections are advised to present their sexual contacts for testing.
Counseling and education these clients we offer is to break the chain of transmission, because if you don't also treat the partners, the infections will never clear. According
to the World Health Organization, 1 million people in the world are infected with at least one type of STIs every day. In 2022, 8 million adults aged between 15 to 49 were reported to have contracted syphilis, with 230,000 syphilis-related deaths reported in the same year.
Remember about COVID, people are talking about the big G. We remember the big G, big gonorrhea. When the lab people worked on it, they discovered it wasn't gonorrhea. It was actually syphilis. The problem with that syphilis was resistant to some of the commonest treatments.
In a bid to enhance screening, diagnosis, and treatment for STIs, this PCR testing machine is said to be a silver bullet, as it can perform 12 STI tests at a go within 1 hour, thereby making it easier to identify drug-resistant STIs and administer the right medication in a prompt manner.
There are 12 tests in a panel. So we do not just the top 3, they were giving you the top 3, but they do a lot of other background, other tests that are usually, some of them are uncommon.
During testing for STIs using this machine, a urine, blood and vaginal sample are presented to the lab. Then the rapid kit for PCR test, which is more specific and efficient, is conducted. Thereafter, if positive, the client is referred back to the clinician, where the management is given as per the World Health Organization and Ministry of Health guidelines.
That test costs us about 4,800 to 5,500 per test per patient. So it's not something that you can scale up that quickly.
Health stakeholders have raised concerns over limited data on STIs in Kenya. This despite STIs posing a serious risk for HIV transmission as well as infertility. Elizabeth Atieno, TV47, Nairobi.
All right, thank you, Liz, for that piece that breaks down the situation, or perhaps the data that is out here by AHF, but of importance is that we have a lady and gentleman from this entity to perhaps even make it better understood by the people. And once again, Gladys, thank you for creating time, as well as Joash. And we get to the question that many have told me to ask, and perhaps that's the reason why I have it as my topic tonight. Is Nairobi the hotbed of STDs? Gladys, do you go first?
Yes.
Is it Mathare or Nairobi?
Basically, we are also having clients who are coming around Nairobi. So it is not basically Mathare. We are also having referrals. So that is not basically Mathare's data only.
Oh, this is across. This is basically what would be coming from different parts of Nairobi.
Yes.
Joash, reality is that the picture is grim, not just in Nairobi, not just, in the country, but globally based on what Elizabeth tells us as to the data from the World Health Organization. What does this speak about, the situation and just how perhaps people are lazily engaging, if you'd want to call it that way?
Actually, if you ever look at the data and compare the WHO projection, it actually kind of conforms with what WHO gives.
Okay.
Because WHO, the projection is we have 1 million new infections every day, STIs, whereby a bigger percentage are asymptomatic.
Okay.
And actually is also what we see in the clinic. But our clinic, we have around 40%, if I look at the data, who are symptomatic,
Okay.
whereby 60% become symptomatic. So actually, it conforms with what WHO projected.
Yeah. So then we are correct to say that there is a national crisis as to the question of STIs, or STIs are becoming a national crisis based on the data that you now present?
We might not say it's the reflection on what Kenya is. Because basically these are a section of the, I think so far we've seen around 45 clients with 527 samples for PCR, done for PCR, because there's the bit of the screening being done before the samples are subject to the PCR.
Right.
So it might not be the projection of Kenya as a whole, but talk about Nairobi, at least it speaks something about Nairobi.
All right. They say what we're going to speak about this evening is critical to, the decisions that people are going to make thereafter. Perhaps paint a picture or just bring us up to speed as to the data that has been presented to us by Liz, and pack it even better now that you sit in there and you have all this data and you understand better and, just looking at the trends.
Okay, thank you. Looking at that data, we'll take it into two. A PCR-based diagnosis, and whereby we are looking at chlamydia, gonorrhea, and syphilis. And then now, we've said that a total of 1,445 clients have seek consultation at our wellness clinic. They were screened and tested. Out of 1,445, 955 were diagnosed with STIs. That is ranging from gonorrhea, syphilis, chlamydia, Mycoplasma genitalium, Trichomonas vaginitis. So out of these, the samples were screened and 527 samples were subjected to the PCR. This is actually where the worry comes in. Out of 527 samples done for PCR, we were having 447 being diagnosed with chlamydia, syphilis, and gonorrhea. So it amounts to over 80% of the tests done. So actually that was the question we were asking. We did 527, then we are having 474. So what is the picture outside there? And now that we are having around 40% walking in just for screening, no symptoms. So we are calling for where we are to kindly don't wait for symptoms.
Okay.
Because also we say that a bigger percentage, something like chlamydia, 50% of people with chlamydia don't have any symptom. So if you wait for symptoms to visit a clinic, it will be too late. We might be experiencing complications.
Okay.
Yeah.
All right, Gladys, just how bold are people to, have the confidence to walk in and just say, do a random check? I have seen ladies, most of the times it's this call, go out there and, have your pap smear done, go out there and, get, of course, tests done to find out whether you're okay or not. But there's always that general fear. And above everything, in these cases, then you see massive, tenets of a stigma I mean, how does it affect, the STI testing processes in Nairobi, and what's being done to ensure that we counter that we have now people who are willingly walking in to say that, well, okay, I have no symptoms, but it's only important that I take a test?
Thank you for the question. I think we're getting more information and more informed and taking charge of our own health. So basically, just working in a facility for STI screening, that tells us that we're getting information and moving away from the stigmatization of STI is basically for people who are promiscuous or associated with immorality. So besides that, the ones who are also coming through because a partner came to the facility and also they would want to know their status of health, we're also getting numbers. I would advise anyone out there, because we need to demystify that STI is for promiscuous people. You could be there and you have chlamydia that's silently not affecting you, but you have it and needs treatment. So creating awareness, intensifying knowledge sharing and advocacy for sustainability in terms of how we value and handle our health is key. Yes.
Okay. It's a large community that basically involves, different faces. Right now we're talking about sex workers. We're also talking about, just family setups. We're talking about Kenyans who are deeply into that space where they are having multiple sex partners. And you want to ask yourself, what will it take for them to be brought from out of that notion that perhaps this has got to do, has got everything to do with sex, and that then they can be twined or twisted to a point where they will warm up to this idea of saying that it's important that you go out there and get screened, not just for this, but basically, for all the concerns that would arise courtesy of these kinds of engagements.
So basically, to achieve this is the environment we create. Basically, is very, very important. So at HF Mathare Clinic, what we do is we offer confidential services, non-judgmental services, and with compassion. So the room we create actually is a stigma-free place whereby when you walk in, you feel welcomed, you feel all your problems are sorted. So basically, the moment we have that environment and everything, it will encourage the patients to walk in, because based on the service I got when I went there, I will refer my friend, who will also refer a friend. Because basically, the best way currently to spread information about something is about social network. So basically, the environment we create there makes referrals easy.
Okay. Yeah. All right, and I'm imagining that you say that, which would be a very good thing. At the facility itself, and perhaps maybe many other branches that you have, would you say that you get to targets that you would expect, say, in a day, in terms of screening or in terms of Kenyans that actually just come in to seek the services?
Basically, days differ, and the flow is not constant.
Okay.
There are days with high workload, there are days with low workload.
But would you say that generally there's that embrace, so perhaps you're doing good in terms of getting Kenyans to warm up to this?
Currently, we are still doing a lot of advocacy, actually. So the numbers are still low as per our expectation, because we expect to be seeing more numbers than what we are seeing currently. So we are still doing advocacy and campaigns so that we can be able to reach as many people as possible. And also we are working with the clinics around and our colleagues around.
Right.
So the numbers are still low.
Okay. What of those ones that would come and come again? Or perhaps one would say that I have taken a test one time and that is good enough, and perhaps they disappear for years.
Basically, what happens is through addiction counseling we offer, because now we equip the patients with information, what they need to do when they come for the first time for the treatment, how the treatment is done, what needs to be done. Because as a clinic also, we have a channel of following up. Because if an individual is diagnosed with an STI, we don't do follow-up to ensure that the symptoms were cleared or this patient was healed from whatever they were having. Basically, we never break the chain of transmission. And Kenya being where we are, we do a lot of over-counter medication. So actually, one of the things also which which makes the treatment outcome not very successful is resistance to antibiotics because of over-counter medication we do. So through follow-up and prompt follow-up, we ensure that even if someone goes and takes years to come back, we are pretty sure that the follow-up treatment was done and the treatment was a success. Okay.
All right. Now let's come to, the questions of policies that actually exist to ensure that we scale up some of, the rapid STI testing processes across Nairobi. What is being used in Nairobi, in Mathare, that you suppose could be different from the other parts, such that this evening we're discussing data that is, hailing from Mathare?
Thank you. At AHF Mathare, we basically one step forward from whatever the market is offering. The most available test in the market is the rapid test and the basic wet preps for urine analysis and the dipstick. We have a PCR machine for STI that is subjecting one sample to 12 microorganisms. So it increases the target and also increases the chance of an accurate diagnosis compared when we do the rapid and basically the microscopy wet mounts.
Okay.
Yes.
All right. Okay. How different, and how can we scale up to these two other spaces in the country, such that then we actually are not talking about this being arrested at the level of Mathare and maybe the other parts of Nairobi, but basically to the country at large?
Actually, from the highlights, our country program director, Dr. Samuel Kinyanjui, actually broke down the cost per patient. So the first question is sustainability. Are we able to sustain the PCR machine in all the facilities in Kenya? That's the biggest question, because cost per patient was estimated to be between 4,800 to 5,000 per test. So that is actually what needs to be considered. If in terms of policy development, policymakers can consider this so that they can give it a priority, maybe every referral hospital to have a PCR machine for diagnostic of STIs. So that would be a bigger challenge in scaling it down.
All right. It's one thing to have the machines and have them right and for proper diagnosis then to be done. You speak of, asymptomatic cases. You speak of drug-resistant cases. So what are we doing to ensure that, STI treatment protocols then are addressed in the sense that, of course, the rise of these drug-resistant cases is literally arrested or perhaps reduced?
Maybe first, if you go through our testing algorithm, we have a way of screening tests, because not all samples are subject to PCR. From the number you saw, we have seen 1,545, but only 527 were subject to PCR. So we have screening tests from what Gladys was explaining. So the entry point for every patient who comes to the lab is urine analysis test. You start with the urine analysis. So depending on what urine analysis will show on the wet preps and also swabs from the genitals and from the source for gram staining. Now, depending on this, the initial test will make the lab team make the decision whether this sample qualifies for a PCR or does qualify for a PCR. Because I walk in, I'm asymptomatic. Then my urine analysis is clear. I don't need to be done for PCR.
All right.
Yes.
Okay. Beautiful. Now, we talk about, of course, the limited concerns of surveillance across not just Nairobi, but the country. And like you rightfully put it, that there's more that needs to be done. Just how much has this engagement been expanded such that then we can have this data coming out so that it helps us as a country to, advise the citizens as well as to make the necessary adjustments?
I think this is a discussion in progress. From this week on Thursday, when we're launching the wellness clinic, the discussion kicked off. So once the discussion is done and we have a way forward, when the right time comes, the communication will be given. But for now, it might be too early to preempt.
Okay, so Gladys, we come back to you. Should STI services, or perhaps in your opinion, do you think STI services should be more integrated with HIV programs in high-burden areas? Because I've also heard Elizabeth highlighting that, of course, while we're talking about STIs that go to levels of gonorrhea, syphilis, HIV then as well becomes a concern that we need to address?
Yes, in my own opinion, it is important, considering that HIV itself is also categorized as an STD.
Yeah.
So that means the behavior predisposes to STIs, not isolating HIV.
Okay.
So, in my opinion, should be integrated, and yes, we should also intensify patient education such that we are informed, we have the knowledge, such that we'll not shy away from getting to the hospital. And also, that is also going to help to clear the stigma that is associated with HIV and not these others.
Okay.
Yes.
What I hear is that you speak of the need for us to have massive public health campaigns. Do you suppose government is doing much of that, or even, talk of private entities? Are they just doing much to ensure that, that STI awareness is raised among Nairobians and basically the country's general population?
One, I feel that the space maybe is not very safe, even when awareness is created, because we've talked about STI is associated with immorality. So when we have the right information and we sensitize and get non-judgmental services in our facilities, then that means we're going to yield. But if we still campaign and not give the non-judgmental, confidential, and compassionate, then we may not get what we're looking for. Yes.
The release of this story by Elizabeth in itself raised an alarm, lots of fears. And I could see on social media people, alarming each other and alerting each other and telling each other, stay woke, chunga sana, and all that. How do we get ourselves from that phase of stigma? How do we get ourselves from that phase of not having knowledge and having knowledge? Just how much needs to be done in terms of, all these public health campaigns that perhaps would be different to tweak the whole situation?
One of the most important things to be done is to alleviate myth and misconception.
Yeah.
If we tackle myth and misconception and we do thorough education, health education, we pass knowledge on what is the expectation, because actually someone will tell you that oral sex has lesser chance of getting STIs. So the moment we address all the concern and all the issues which are there, and good advocacy, and we have good channels, because we can do all this, but are our health sector welcoming? Because advocacy will be done through public health, everything will be done. But when you go to the hospital, you don't get the service. Actually, that's what now will make people to get tired, deter people from going to the hospitals. So with campaigns, education, and alleviating the myths, we'll achieve what we need to achieve.
Okay.
Because actually, from where we are, we started small at HF Mathare Clinic. And as we are going, the numbers are growing slowly. So as we keep doing the advocacies and the education, we see numbers are coming up.
Okay.
So it is a possibility.
All right. So we talk about sexually transmitted diseases or sexually transmitted infections. What are some of the misconceptions, top of mind that perhaps people would have that you would think would be necessary to be scrapped off so that moving forward we embrace the need for screening, we embrace, the need for shunning, stigmatization and all that?
To start with the first one, which Greg mentioned before, is we associate STIs with promiscuity. That if I go there, the only thing they'll think of me is I'm promiscuous.
Okay.
Or maybe I'm a sex worker. Then they believe also I need to have symptoms for me to think I have STI. So first we have to remove these and tell people that not a must. You should not wait for symptoms.
But most of the people will tell you that when they get to health facilities for help, in such cases, these questions will be asked to you. Why have you come? When was the last time you engaged? Why do you think? Why do you worry? Why do you think it's necessary for us to take this screening? I mean, when it gets to that level, how do we then get the confidence that perhaps I could just walk in even though I do not have the symptoms?
In treatment, We have 3 sections.
Okay.
One is where the patient presents with the symptoms they have. Then as a healthcare worker, I will do examination based on the findings. Then based on the findings, I will tie both history, because in history taking, we say that we use the 5 Ps approach, whereby we are concerned about the practice, partners, pregnancy intention, past histories, and then from there, we do physical examination. Then I tie all these things together. Then now I will have an impression of what you might be having.
Okay.
I might suspect syphilis, I might suspect chlamydia, I might suspect gonorrhea, basing on the symptoms and the examination findings.
Okay.
So basically, the questions we ask, it's part of treatment. So when the expectation of many of the patients that if they come to the facilities, they shouldn't be asking any question.
And if the questions are asked, which is okay, are there instances where, you know, maybe the process ends at that level of questioning because maybe the medic or the clinician has, you know, examined you, perhaps listened to what it is that you have said, and they probably do not even see the need of beginning the process of screening?
The process ends at the screening test in the lab.
So it must happen?
Yes.
In most cases?
Yes.
Okay.
Because that is when now we'll be able to tell, because we've said you have numbers who are symptomatic, which means history, there's no presentation.
Okay.
Physical examination, no significant finding. So the only tiebreaker here will be the screening test in the lab, which is a urine test or a prick for syphilis.
Okay. Let's talk to the vulnerable groups, Gladys. Is there any targeted support, and you know, as AHF and perhaps generally with other entities that is available for, you know, persons like, say, sex workers, MSM, you know, and their PrEP users with high STI rates?
Yes, basically at AHF, we said we offer non-judgmental, compassionate and confidential. So that tells us we do not discriminate based on the sex orientation. So we're encouraging many of them to actually pop in at the facility because they'll get the help that they need. Also for the PrEP users, also for the people who use PrEP more oftenly, that means they have exposure oftenly, which also predisposes them to, besides the STIs, also HIV. So yes, we do screening for them also, as much as we give the PrEP.
Okay.
Yes.
Maybe just to add also, we're having partnership with most of the organizations, like the organization supporting the MSMs and the organization supporting female sex workers. So yeah, this collaboration. So I think everywhere we go, you talk about integration. Integrating services is the way forward now. That's where we are headed to. Because even if you come to Madara HF clinic today, we offer integrated services. Because under the same roof, we offer wellness. We have the wellness clinic. Under the same roof, we have the HIV care and treatment clinic. Under the same roof, we offer TB care. So integration is everywhere. So collaboration, yes, we collaborate.
Okay. And I remember my times of perhaps just getting to learn about the STDs pretty much at a young age, taught in school. You know, and therefore that means at the level of education, there's a way we embrace the need to enlighten the masses as to the dangers and, you know, most important, the preventative measures that can be taken. Do you suppose schools generally, universities at that level, are doing enough to ensure that, you know, there's enough education, especially to the young people, about STIs? And when we talk about this, do you think they're using the right modes for them to get to understand better? Gladys, we could take it.
Maybe the information is there, but the mode or the channel. Because for the young population, or popularly Gen Z, basically I think for them to get the information is actually through social media, majority. And so when we put it on the mainstreams, we may miss the target. The targeted audience may not get the information. There is also a lot of that needs to be said and done in terms of screening in the universities, because they also feel there's a lot of freedom and there's also a lot of peer pressure. So if we do not have targeted campaigns self-awareness being done in the universities, then we still continue having the same problems because we said majority of the patients we see, it's age 15 to 35. So that means they're falling under the category that we're having who are reacting for or who are testing positive for STIs.
Yeah.
So that means we have targeted testing or screening in the universities. This could help us break the chain of transmission.
Okay.
Yes.
All right. Much is being done in terms of, education. And should it end there, that, we're talking about elementary, we're now coming to university, and, it just ends there?
I think where the government is still not doing well, or the policymakers still not doing well, is we need to incorporate the sexual and reproductive health into the curriculum, whereby we have a module whereby the students are taught in colleges and in primary and secondary schools, such that we get empowered with this information from younger age, knowing that if I see this, I need to do this, I need to do this. So one of the things which we need to do is incorporate sexual and reproductive health into the curriculum.
Okay.
And it will be able to help.
All right. Let's talk about, preventative measures, which is critical. And as a country, we're at that level where we're talking about how best we can prevent us from getting, health concerns, diseases and all that. What are some of the things that people need to understand, take home this evening, that would be helpful for them to prevent themselves? Because I am actually just looking at basically how we operate, the question of condom use, as well as the gender norms that continue to exist. The cultural attitudes around sex, and gender, as well as how they get to affect us, and relationships, especially when we're talking about, the use of preventative measures.
One of the things we need to do in prevention is we need to do campaigns in the communities, because there are some communities whereby you can't talk about sexual health. Discussing sexual health is a taboo.
Yeah.
So we need to break this in the communities, such that people can discuss sexual reproductive health freely, so that we know what needs to be done. You talk about in prevention about condom. You don't just about condom use. You talk about consistent and correct condom use.
Okay.
So continuous education about consistent and correct condom use helps in breaking the transmission chain. The other bit is partner. If you check how we take history, actually we go 6 months. We date back 6 months. You have sexual contacts for the last 6 months.
Yeah.
Moment I'm diagnosed with an STI, my sexual contacts for the last 6 months need to be traced and be treated. But the referral system is whereby actually the type of care we give currently is a shared decision type of care. So I will ask for the sexual contacts will be given, then we'll agree on the modality to reach the sexual contacts. Because if you treat the sexual contacts also, we are breaking the chain of transmission, what we call pattern notification.
Right.
The other bit is health education. Today, if a client walks in, we don't just treat and let them go. We offer preventive education, such that if we give them the education, they will scale it down. Basically, the reach will be wider.
Okay.
At the same time, apart from the partner notification, condom, health education, I think basically those are the preventive measures which needs to be done. And now the last one is treatment with follow-up.
Yeah.
We have to ensure that we follow up these patients when treatment is initiated and the treatment outcome is a success.
Yes, and most people will tell you that they struggle with that element of treatment because, number one, there's of course that concern of stigma, so they want to hide themselves as they take the medication. Some will tell you that, of course, it's a question of the things that you have to eat while you're taking this medication, the ones that you're not supposed to. Some will tell you that there are timings that are very critical as to this. Could you just walk us briefly through, some of the things that people need to know? Perhaps if there's someone right now who's taking the medication that they must adhere to.
So basically, with prescription medication, there are different medications require different instructions.
Right.
And for every time they're prescribed, something like if today I'm given doxycycline, we'll tell you to avoid milk. So every time we give prescription, the advice is always given and the instructions on the do's and don'ts, because we have a wider range of the medication we give. Breaking them all one by one will take a longer time, but the most important thing, and as why we discourage just going to buy drugs over counter, kindly get tested, get to a health facility where you'll be treated based on the isolated organism.
Okay.
Then now, based on that, you'll be in the correct medication, and the instructions will be given so that you can be able to achieve the therapeutic desire of the medication, rather than just taking medication without the instructions, because basically that will affect how the medication works.
Okay.
So I urge all healthcare workers outside there who are giving treatment or offering treatment to patients to kindly give correct instructions as we are dispensing this medication.
Okay. Some people would then ask, upon of course being diagnosed and you have been given medication or you are undergoing treatment, do you engage intercourse sexually and all that? Or if you must, then would you use, say, a condom or what?
The best answer we always give, or the best counseling we give, is we abstain during the course of treatment.
All right. How long would it be, roughly?
When the treatment is done...
And I know it's different for yeah?
Because basically, the recommended follow-up for any STI treatment is we're supposed to do a test follow-up after 3 months of completion of treatment. But moment the medication are taken, the way they're prescribed, we will achieve the therapeutic index, and then we'll be fine. The only thing we don't need to do is, if I'm diagnosed with an STI, I can't say my partner didn't test, because the mistake we do, which we see in the clinic, is the partners now. I'm diagnosed with STI. I bring my partner, they are screened, they screen negative. Then they'll tell you, like, I don't have the STI, so I can't get treated. So the information here is, moment your partner is diagnosed with STI, irrespective of your test results, you need to get treated for that STI. Because we have two things. We have incubation period and we have window period. Because the window period is the duration it takes for the test to turn positive. So maybe I have the infection. By the time I was doing the test, I was in the window period. Automatically, my test results will be negative. That is why we say in STI treatment, partners are treated irrespective of the results, provided your partner has an STI.
And I'm coming back to understand that some more, but back to you, Gladys, who is more of a techie. Just how can clinics in informal settlements, for instance, build trust as well as improve health-seeking behavior? And I know we have touched a bit on that.
Thank you for that question. The informal clinics, basically, one, we need to sensitize our healthcare workers. Maybe you know me, and I just pop in and you shout my name, and everyone now knows me. I came for STI. There's no confidentiality. Secondly, we need to normalize. It's just like a flu. I came for STI. The way you wouldn't make a big deal out of a flu, the same way we expect that we treat the STIs. That way, you're going to build the confidence of the people around us who want to seek medical attention in relation to STI in the informal settlements. We are also encouraging referrals. Maybe whatever they've examined, they feel it's something they can't handle, there's always a referral system, which is also part of patient management. Encourage the patient and give the information why they need to get to the next level to get treatment. I understand there's also a challenge of maybe medication in our facilities. So maybe if there is we've said a referral is a part of patient management. Encouraging them to seek medical advice and explaining why they can't get the service they needed, so that they get the importance of getting to the next level to get the help. Yes.
All right, back to understanding the question of counseling as well as, infections and all that. You say that there are chances where you would come with your partner and they are screened and they are negative, but it's important that they undergo the treatment. Are there chances that you could be with your partner, you have engaged, sexually, and you are positive and they are negative, and that chances are that they would still remain negative all through? Like, is it a must that when you engage, then automatically you'll be infected?
No.
Okay.
It's not a must.
All right.
But in the bit of not taking chances, because there's the bit of resistance.
Yeah.
There'll be temptation that once I'm done with my treatment, then now we can engage sexually. Then how about the time I was being tested, I was in the middle period. So it's not cast on stone that if my partner has, I have to. But it's a precaution we are taking as healthcare workers, that we avoid getting a resistance strain.
Right.
Yes.
Okay. Let's talk about counseling. Just how critical is it in this process, and especially when there's that involvement of partners?
To achieve the desired goal for any treatment, counseling plays a very vital role.
Okay.
Because this is the time, this is the process which makes me understand what I have. This is the process which will make me understand that if I don't do the right thing, what are the complications? And why do I need to take this medication?
Right.
So counseling plays a crucial role in treatment. As a clinician, I will give all the information. The client will be given the medication to go home. But psychosocially, are they okay? Emotionally, are they okay? Because by WHO says health is well-being socially, physically, emotionally, not just mere absence of a disease.
Okay.
So I've given you medication, you are going home. But have I taken care of the psychosocial issues? So the goal of treatment is we offer all-round treatment, the package as a package. So all the clients we see, we have to. As clinicians, we need to equip ourselves with counseling skills.
Okay.
Because if we refer all clients to the adherence counselors, we are going also to increase waiting time. So we only refer to the psychologists and the counselors where there is more need to be assisted. But if it comes to treatment and counseling about treatment, as clinicians, we are able to do it, and it's part of treatment.
All right. We talk about, that doctor-patient relationship and the need for, a patient's information to be kept, private and secret as you would be. Just how critical is this data that you establish, in terms of, helping the people? Because then when you release out there, it is likely to as well bring in some level of, perhaps the feeling that the people would have that, you cannot trust this facility, because if you're going to go out there, today they're going to release this information as data, across. Maybe the next time, information that is very, very personal would find its way out. So how do you use this information to the advantage of the society or the community, and at the same time avoid that unnecessary fear that would come with people feeling like, okay, this is not a facility that we can trust, because if this data is going to be released out, it means that even personal data, is really not protected.
Thank you for the question. At AHF, when a patient walks in, at the triage we give a unique number, and we also use electronic medical records. Everyone with an account is password protected, so that means you cannot access the information apart from whoever is providing the medical support.
Okay.
So when we come to data, we do not disclose the data or the names. We talk about the numbers that are supposed to help in decision making and informed policy making. So anyone who walks in there shouldn't be worried about the confidentiality, because we are using System, the EMR, and we're also giving a unique code to every patient such that they are identifiable by their code in the system. So you wouldn't get to know who exactly the patient is without the access to the system.
Okay.
Yes.
Well, apart from this data being released to say at, media and all that, how else is it being used to enlighten the masses, perhaps even that Mathare community, before it extends to the rest of the country?
So basically, data is important in policy and decision making.
Okay.
So, like in Mathare community, today if we see, because as the end users, we are able to see the location or the residence of each and every person. So if you see there's a specific area where there's dominance of a specific condition, so we offer targeted outreaches and health talks and campaigns and advocacies so that we can be able to break the chain and be able to set the community free of the infection. So basically, that is how data is used. Apart from resource allocation and everything, is still a part of data, because today, how will I assess that there's need, that a specific community, let's say in Korogosho needs this service, is based on that data which is going to be there. Then now, if that data is analyzed, we use it to make that decision to take the service there which they need. Targeted.
All right, executive order, or Trump's executive order, pretty much dealt a blow to, how best we could deal with, these concerns. And we just get to understand that there's been the exit of the likes of USAID, PEPFAR, and many would say this in a huge way impeded the fight against STIs as well as HIV. How do we get to bridge the gap, or how are we actually bridging the gap? Have you felt the impact maybe as AHF?
Basically, the impact has been felt. That's why you get currently healthcare is moving, we are moving towards integration. We are integrating services. Because you check, like earlier on, like HIV care used to be standalone services, whereby you used to have a specific area for offering this care.
Right.
But with integration, now we are moving services back to the outpatient. Now there is no specific point where we say these are point this service is being offered. So with integration, you get the human resource will not be felt as much. Because now the patient will be seen with a pool of staffs. Vis-a-vis how it used to be standalone. So integration is the way to go to curb the fund cut by the USAID and
most people are asking, please break it down even further so that we know the areas to go to and where not to walk and all that. Sometimes some of them are actually asking, if we're going to look at the data, does it speak of, the women who are actually the ones who are infected more, or the men, specific areas perhaps, that people should look out for and be careful?
Actually, in the data we presented, 53% of the clients we see total are men. While 47 were women. Now, it is a reverse if we went to the PCR. PCR women were higher than the men. But about the location of where to walk to or not to walk to, it might not be easy to tell.
Just be careful.
The only thing is be careful.
Right.
Come to the clinic, let us test. If it is there, let us treat to break the chain of transmission so that you are sure of your state as you're outside there. But telling you that don't walk there, how about if you're the one having the STI?
That's true.
Yeah.
So you're saying PCR at that level, that is now at a higher level, it is the women that were most. What informs this? Just to enlighten us, or perhaps remind us of some of the things that we learned about, some time back when we're learning about this, that some of these symptoms are manifested faster and more in men than women, or what exactly? There are some specific infections which affects women more and some affects men more. But why are women more affected than men? It's the surface area of our reproductive system. So you get they have a larger surface area compared to men. That's why you will get, for most of these infections, women will be more affected than men are affected. That's basically the biggest difference which is there. All right, that's great. What does it speak about now, the levels of HIV in some of these areas that we're talking about, perhaps in Nairobi and Mathare for that matter, if you're going to tally the same with the STDs that we have talked about?
I might not have a specific distribution, HIV transmission distribution as per gender in Nairobi or in Mathare as at now. Maybe that if it's looked at, maybe it can be shared.
All right. Okay, so if you're going to talk to the people today, what will be this one thing that you tell them they need to do, because it's critical that then we are alert, we stay woke, and we get to understand the best ways to move. And know in the process of this discussion, we have as well highlighted some of those, but what would it take for us to change this? to being a lower number?
Basically, what I can tell the people now is that let us get tested. Let us know our STI status. Let us get the appropriate treatment after testing.
Okay.
Because I might get tested, but don't get appropriate treatment.
Okay.
Then the health education, which is being given, let us break the chain of stigma at the community level. And to the healthcare workers and the health facilities, I would say let's make our services friendly, confidential, and non-discriminatory.
Okay.
Because basically, if we discriminate and our services are not confidential, basically, no one will walk in. So we test, we treat, then we spread the information. Okay. Let's be the ambassador of change. All of us to be the ambassadors of change. Let's not say it is the work of healthcare workers. It's the work of the public health officers to do the health education. Health education is the role of each and everyone. Because if I talk to my friends and they are helped, the society is helped.
Okay.
So if I say I have to wait for the public health officer to come and give the information I can give it, we'll not be able to help in that.
All right.
As well as we say as HF Kenya, our services are free. We offer free services.
Right.
So our gates are open, our doors are open. Walk in, come, get tested, and get treated for STIs.
And Gladys, I am glad that we're talking about testing and all that. It reminds me of some time, should be early this year, when there were, cases or fears that the HIV and AIDS test kits were not, in the best of shape, in that, of course, even the results they would give were a bit faulty or a bit off. Just how many times should one test or be screened to confirm that indeed that this is the case? Because also I've heard of people who have said, I went to this facility, I was screened, and I was told I'm okay. I went to another, I was screened, they said it's positive. I now want to seek a third, of course, facility, advice from a third facility, so that I am certain as to whether I should begin treatment or not. I know you speak of what you have at AHF as to be high end. But what is there a need to always redo the screening and the test before someone begins the treatment?
Basically, as my colleague has said, we buy more time. We talked of the incubation period.
Yeah.
You came today at AHF. We screened for STI and we tested. It tested negative. But then, or it tested something. Then in your mind, you have a doubt if it is, you go to another facility. And mark you, take note of time. If you're doing urine, the morning sample will not be the same as the evening sample.
Okay.
You have urinated the whole day. So there is also a likelihood of missing something. So you go to a facility in the evening and they screen and tell you actually don't have something. You go to facility X as number 3, and they actually screen and tell you have something. So the time you wasted seeking for the third, second opinion, you'd rather get treated other than wait for the symptoms now to come, and even maybe worse. So I would tell, if you're coming to a facility and you actually screened and there's something, in my own opinion, get the treatment, the early, the better.
Okay.
Yes.
Just how safe is this treatment? Because we also understand that there are cases where you will undergo treatment and the medication wasn't perhaps necessary or wasn't the right diagnosis, and therefore you find yourself taking medication that is not good for you. If I am going to, if my screening reads negative, really, why should I proceed to get treatment? Just how safe is this treatment? Because this is a foreign body that you're introducing to your very own. That is safer to take them so that you do not get to have the infection ultimately, or it is safer to be sure, double check, cross check before you begin the treatment?
Basically, that's where the history comes into play.
Okay.
Because you've come today to be screened for STI. You screen negative. The biggest question we ask is, because that's why in one of the P's, we ask about past STI treatment history.
Okay.
And has your partner been treated for STI in the recent? is your partner currently having an STI? Because today, if you walk in, you tell me for the last 6 months, you've not been sexually active, you don't have any partner, then you screen negative for STI. You don't need treatment.
Okay.
Because where would you get this from?
Okay.
Because with the history and the physical examination rules out everything, and the screening test is negative, you don't need treatment. Vis-a-vis, when your partner has an STI, which is confirmed, your partner has gonorrhea today, then you screen for gonorrhea, then you screen negative. Now brings the two statements I said, the window period and the incubation period.
Okay.
The window period is the period between infection, between the time I acquire the infection to the time I test positive.
Okay.
So maybe the time I came for testing, I was still within the window period. So I had not converted to be positive. So my test results will be negative. That's why today I go to facility A, the test is negative.
Okay.
Then I say, my partner has it. I want to seek a second opinion. Then I go to facility B, then they tell me the test is positive. Now, I don't know who is right. Is it facility A or facility B? This is where now the counseling also comes into play.
Okay.
We make the patient understand why the possibility of test at facility A was negative and why at facility B is positive.
Okay.
Because of the window period. So basically it is history and physical examination and the sexual contact determines the treatment.
All right. All right, so upon diagnosis and all that, or even before diagnosis, if we're going to overlook their symptomatic cases and look at those ones that have symptoms, we are talking about gonorrhea, we're talking about syphilis, chlamydia and all that. Just how much of a difference is there in the symptoms that lie in, or what are some of the symptoms to look out for if there are people who are watching us tonight and, perhaps they have these specific symptoms? What are some of them that would necessitate them to proceed to a facility and actually get screening?
Thank you for the question. Symptoms may be very similar.
Okay.
Very similar. We have pain during urination. There is itchiness in the private parts. There could be lower back and abdominal pain.
Okay.
We could have general body malaise, and actually the discharges, urethral or vaginal. And basically, the symptoms be very similar for chlamydia, gonorrhea in a lady, and the same for men. So only you walking to the facility and we getting the sample is what will give the difference, is what will give an accurate diagnosis that this is chlamydia and not gonorrhea. So basically, the signs are more general.
Okay.
They're not specific to one infection. Yes.
All right. You talk about the timelines, maybe incubating period to a level where, of course, the symptoms are now clear and all that. Is it different for different people, or we would say it's like they would rightfully tell you, maybe with HIV and AIDS, wait for 3 weeks, wait for 3 months to take another test and all that?
Basically, the incubation period varies depending on the individual's immunity. Yes. So that's why we have a duration. You get like gonorrhea, you're told between 2 to 14 days.
Okay.
So mine might manifest in the first day or the second day, but the other individuals might manifest on the 10th day. So immunity plays a role here. The other bit is the inoculant dose. The amount you got will determine also the progression of this treatment. The other bit determines the show of the symptoms. The other bit would be the underlying conditions will also predispose individual to have faster progression to these conditions. So basically, it's the inoculant dose, immunity, which plays a role, and also the nature of the specific conditions I have, because there are some which goes to 90 days. So the incubation period might be longer compared to the other one. So it's not standard for all the infections.
And then in the process of treatment, upon confirmation that one maybe has one of these conditions, how then do they behave moving forward in terms of nutrition and as well as how do they, because this is critical for most of the people who might not have this knowledge or information. Sometimes you're told, okay, fine, if you're not going to engage sexually, at least avoid sharing things like towels, avoid sharing, personal stuff, avoid sharing this or avoid these certain foods. Just how critical is nutrition in this case, and how do they carry themselves moving forward so that they avoid a scenario where, again, there's going to be an infection that perhaps is even transmitted, not sexually, whether there's some truth in that or that's a myth.
We've talked about counseling and education, post-treatment. So after the isolation, the clinician takes through the patient on what could be the cause. How could this pathogen be transmitted from one person to the other?
Okay.
In terms of nutrition, there's also the nutrition advice in terms of how do you best raise your immunity or make your immunity better. Because we do not want to preach the dependency on medication.
Okay.
We also need to up our bodies that they can also fight before we get to the point of medication. So that basically where education and counseling comes in. Yes.
All right. Anything that you'd want to top up on the same? I see you have something to say.
So maybe to add on what my colleague has said.
Yes.
If it comes to modes of transmission, it's important to understand modes of transmission.
Okay.
Because we know that the way we transmit STIs is through sexual intercourse, which can be either anal, vaginal, or oral.
Okay.
Contact with body fluids when you have a cut. And the other bit would be skin contact. There are specific STIs which will be transmitted through skin contact, something like pubic lice. So the moment we understand that, we'll be able to know, because now there's this myth that we can get STIs from toilet seats. The question is, this bacteria takes how long to survive outside? Unless it is very fresh, then you get into contact with it, you will get it. So basically, we can't get STIs from toilet seats.
Okay.
Yes. So the other bit, talk about nutrition. Nutrition, there's no specific nutrition for the treatment outcome to improve, is what we have. The only thing is now the instructions we give for specific medication that avoid specific things.
Okay.
Like the example I gave of doxycycline, avoid milk.
All right.
But we don't have a special diet that now that I'm on this treatment, I have to take a special diet.
Okay.
No. We'll just give instructions on what to avoid. But normal food, provided not told to avoid anything, kindly eat as usual and take your medications as prescribed.
Right.
If it is twice a day, make it twice a day. If it is 3 times a day, make it 3 times a day.
Okay, but above everything, we say we must get ourselves to, be careful so that we are preventing, these cases from arising. Thank you so much, Joash Mbuya, Clinical Officer, AHF Malaria Clinic, last speaker, as well as Gladys Mwangi, Medical Laboratory Technologist. Asanteni sana for the great insights. Massive, response, people asking the general questions, but I hope that we have managed to touch on some of the things that you would have wished to understand this evening. And this is where we're going to close the TV47 Weekend Edition. It was great having you. Thank you so much for always keeping it at TV47. I appreciate your presence as well as your feedback. And once again, our guests tonight, Asanteni sana for the great insights. You need to stay woke. Indeed, they confirm that based on data, Nairobi can, confidently be labeled the hotbed of STDs, STIs, if you'd want to call them. So please be careful. And as they would say, avoid multiple sexual pregnancies or multiple sexual activities. My name is Linda Alela, of course assisted by my sign language interpreter, and none other than Roda Nyamai, appreciating you tonight, as well as saying thank you to the rest of the team for making the broadcast a success. Do have yourself a beautiful week ahead. Good night. Thank you.